So we are all welcome to you, and we are very happy to receive every participant here, and hope you will enjoy this and to share your idea and your concepts after this webinar. Thank you very much, all of you, and thank you, Dr. Mahmoud Shihab, the pioneer of total knee replacement surgery. You have the mic. Thank you.
Thank you, Dr. Sinan, for this nice introduction. I hope I will be a pioneer, but we say still we are small. So because whenever, as you do more surgery, you think you are, there is a wide aspect of knowledge you must relate to your surgery. Today, and also I thank for Mr. Kindi for this nice activity and invitation to give this lecture. Also, I am saying that for all the doctors, my colleagues, who's interested in this field, all they will be interested in this field. They get some principles regarding one of the dangerous complications and disturbing and annoying complication, which is periprosthetic infection. In my series of this lecture, I will get to 3 steps by steps. First, to the prevention. There will be many lectures. Then diagnosis, how you diagnose PJI, SSI, and then the treatment. Just one thing. This knowledge which is introduced in this lecture, it's contributed to the ICM International Conference meeting, which achieved in 2018. So every knowledge, it's depend on hundreds of lectures, which is achieved by pioneers all over the world. Then it is documented and written. So what we are doing as doctors here, we try to correlate and to apply this principle as it's possible, even 50% of this principle, so to get away from this complication. Just for who's they are not attending the last session before 1 week, just I will give brief, then I will start my new lectures. It's about periprosthetic joint infection. Last week we started it's okay, slides, Sina? Yes. Last week we started about what is the factors which affect the biofilm formation. We talk about the host factor and concentrated on the host factor. The host factor, which is include the nasal swab. Why we concentrate in nasal swab? Which type of antibiotic organism there? Then we talk about drugs which must be continued or stopped before the surgery, and what drug to be continued after surgery. Then the disease which was analyzed and by blood parameters. Then we talk about the skin preparation. We concentrate at that time on nasal swab, because most of the Staph aureus and MRSA is common cause of PJI, and it's about 25% is present in the nasal swab. And we get a document that addition of MRSA and MSSI screening of them preoperatively will result in decreased SSI by 70% by simple screening of the organism by swab. Then we get to the second factors. We talk about the drugs, which is mandatory regarding anti-rheumatoid and anticoagulant and glucocorticoid. And we talk about the rheumatoid, the traditional drugs and biological drugs. Then we go to anticoagulants, what type of anticoagulant to give and what type to stop. Then we talk about the cortisone, which is how much it's mandatory to stop before the surgery, milligram, and when you giving the stress dosing. After that, we talk about blood parameters. In blood parameters, we concentrate on three diseases, which is the anemia and diabetic and malnutrition, and how we diagnose them and how we correct them, and what is the landmarks for the hemoglobin, for the diabetic, and how much it is accepted before the surgery. And we talk about the malnutrition, protein, and iron, and what drugs we can, what diseases we can deal with it. And the last session was, it is the skin preparation. Before you are going to the surgery, what type of skin preparation you can apply it, when apply it, before 48 hours or directly before the surgery, what type of solution we suggest that is better to use it in preoperatively, and what's about the hair, and what's about the intraoperative, the op site, or the what type of solution to clean the wound, the skin. That's why the just abstract and short review with the previous talk. So now we will go into this our lecture. Those with doing surgery or working in this field, they may see these pictures and face it in the clinic, in the hospitals, in different stages. So all of them, they take TKR and present you like this. So this will be a natural history who's working doing the surgery. To avoid these things, to avoid these pictures, to avoid these complications, and to not end in this type of pictures intraoperatively, and to avoid to put or to escape from this complication. And always we try to say, oh, this is not infection. We say, my message to my colleagues, open the window, deal with these cases. And you, if you feel it's difficult, or in your hospital there is no principle how to diagnose OTRI, can refer it to other center to deal. But we are, as a surgeon in Iraq, we must face this complication and deal it, yes, slowly, but the end will be very successful for us, especially when are doing huge number of total knee replacement. Always you must plan. When you are going to a trip, to reach the end trip, always you are checking your car, you're checking the tire pressure, you're checking the petrol, then you start your trip. Same for the total knee replacement. Please plan before doing the surgery. Planning starts from the prevention. And that is why the prevention, very important. Why? To avoid the high mortality, high morbidity, and to avoid, in less, some cases, mortality. So morbidity and mortality by plan, you will be very little. Regarding the prevention of PJI, prophylaxis antibiotic, we will talk about the molecules, duration, and those drugs allergies, and the patient risk also sometime on revision. Our main aim is to avoid the pathogen or microbe to get inside the wound when you are doing the surgery. This is our main rule, because most of the PGIs in total knee replacement is coming from the surgery. I'm excluding those coming with the hematogenous, but most of them coming from the surgery. Before, in 1988, there is a literature by Lidwell, within the first year after total joint replacement, I am saying total joint replacement, hip is included, 95% of the bacteria causing pre-prosthetic infection are due to contamination from the skin flora, intraoperative contamination. That's why I am saying the prevention is very important. Before about 100 years, Moynihan said, every single surgical procedure is an experiment in bacteria. There is an equation. By this equation, you know how the infection is occurring. The equation depends on the number of the bacteria and virulence of the bacteria divided by the host defense. So by this equation, one increase, decrease, you get infection or no infection. Okay, the questions, are antibiotics able to prevent surgical site infection? The answer is yes. Just we get this sample, peritonitis after elective colorectal procedure. In these cases, number of the bacteria is huge, the virulence is big, and the host defense is weak. So mortality rates without antibiotic about 30%. There is one of the basic study, which is done before they giving antibiotic after the surgery. They get investigation, of course, in the animals. They give antibiotic 1 hour before the incision and giving antibiotic after 6 hours after incision, of course, compared to control group. The timing of preoperative prophylaxis, they achieved, or the result was, whenever it is approaching the skin incision, is better when you are avoid or away. So in this diagram, you see if you give it before 3 hours, the first column, if you give it before 3 hours, or you give it after 5 hours, the last column, the infection rate will be high. And the best when you give him 1 hour below -1, 1 hour below the incision, the timing of the preoperative prophylaxis. So if you compare it, the column of 1 hour to the 12-hour preoperatively, or giving it postoperative or placebo, the best time is preoperative to get less PJI or SSI. Monogram classification. Let us to classify our wounds. Classification, class 1 is clean, class 2 clean but little contaminated, class 3 contaminated, class 4 dirty, infected. Regarding the class 2 and class 3, we need prophylactic antibiotic. Class 4, we need therapeutic antibiotic. But total joint arthroplasty is clean procedure. Does we need prophylaxis? The answer is yes. Because there is very short period. When there is the wound is open, the microbes trying to escape from the skin to the wound. There is little period that can try to escape from this, jumping from this to the wound. Then after the closure of the wound, the infection may be like hematogenous. But this short time, it is very dangerous and very important for us. These bacteria will jump from the flora to the wound. They are less in number and planktonic, it is suspended. So when we reach to the equation, number of the bacteria is low, virulence is high, and host, you know, it depend on it. So if we don't give antibiotic in this period, 10% of our cases will be PJI. So now we are coming, how we perform our perioperative antibiotic prophylaxis. There is 3 factors. First, chewing of the antibiotic. Second, onset of the action of the antibiotic. Third, duration of the antibiotic. To choose the antibiotic, this antibiotic must be optimal action on staph and strep, because most of the common cause of PJI, this is staph and strep, and has extended half-life where it's active and highly concentrated at the site of operation. Also must be with low frequency or low percent of side effects. What's your choice of antibiotics? First choice is cefazolin and cefuroxime. When you have allergy to these, you can use vancomycin, teicoplanin, or clindamycin. If there is not one organism, if there is a multi-resistance organism, staph, you can give him vancomycin 1 gram IV before incision. If they are multiple resistance organism, but it's negative, you can give him mironine preoperatively. It is not just the antibiotic, of course, with the antiseptic washing of the skin, that to prevent the PJI or SSI. Now, we come one question in international consensus meeting. What is the most important, what is the most appropriate perioperative prophylactic antibiotic agents and route of administration and the doses in patient undergoing primary total joint arthroplasty, hip and knee and elbow, all of them, to reduce subsequent SSI and PJI? And this is carried by 3 scientists, and the literature's a lot of meta-analysis and prospective randomized and retrospective study, including multi-center. What is their recommendation? The recommendation is agreed by 90%. The most appropriate preoperative prophylactic antibiotic is the first or second generation cephalosporin, cefazolin or cefuroxime, administered intravenously 30 to 60 minutes before the surgery. And this document agreed about by 90%. But must be related, the route is intravenous and related to the body weight. Body weight depend on body index. If it is the body weight below 60, you get 1,000, like example. And if they are above 120, you go triple doses. So the literature's done is they classify them to 3 groups: less than 30 BMI, 30 to 40, and above 40. If you are before 30, you need about 40 milligrams to concentrate in adipose tissue. But when your body index is more, you need more doses. Like this, if it is more than 40, you need triple the dose, the original dose, to reach same level, which is below MI 30. So if the patient obese, put in your mind, you may need the preoperative antibiotic triple doses. Instead of 1,000, you must give them 3,000. Okay, now we choose the antibiotic, type of antibiotic for the positive and negative, if it's a single or multiple organism. Get to the, what's about the onset of the antibiotics. Onset of the prophylaxis. The intended drug concentration at the site of the procedure must be at the time of skin incision. Please, this is very important. Whenever you start the incision, the antibiotic must be there. So it's better apply it with anesthesia 30 minutes or 1 hour to start your antibiotic and slowly. Just for the vancomycin, because it has slow action, you apply it before 2 hours before the skin incision. This is how to onset of the antibiotics regarding the vancomycin or the first generation of cephalosporin. The third question is, what's about the duration of antibiotics? This is the most critical period. The action of the and effective of concentration must maintain until the last suture is done. So it's better to apply slowly till last suture. During the operation, all of the antibiotics must be there in the wound. This is first. When you are trying to redosing another dose for the first dose, first when the surgery is more than 4 hours or there is blood loss more than 1/2 liter. So for the first generation, you apply first redosing after 4 hours, vancomycin after 12 hours. And if you have loss of the blood, you get to redosing. This is 2 indications for redosing. Then we come, what's the benefit? We just extend the dose, or it is just day of operation or 1 day. There is many studies, Williams on 1984, they observe 1 day post-operative as good as 3 days. Nielsen at 1983, 1 day post-operative as good as 7 days. And McDonald say single versus multi-dose, the same result. So NHS sign, they recommend after, of course, hundreds of literatures for the arthroplasty up to 24 hours of antibiotic prophylaxis should be considered for arthroplasty. Just for the first 24 hours. It's important to do the antibiotics. Okay, the other question. It is good for apply single doses or extended doses. Single short dose with the anesthetics to start is better for the extended doses. Why? Extended doses, that mean operative, intraoperative, and when the patient go to the ward, the antibiotics continues with it. Because it induces drug resistance pathogen, MRSA, first. Second, may introduce Clostridia difficile associated disease, Clostridia. Third, they may spread of these pathogens. So extended prophylaxis, it's not recommended in ICM. And what's the guideline with the World Health Organization? Antibiotic prophylaxis, the panel recommends against the prolongation of antimicrobial prophylaxis after completion of the operation. One question highlighted in ICM, is 1 dose of perioperative antibiotic adequate to go undergoing total joint arthroplasty? And this by 3 scientists. The literature also randomized, retrospective, meta-analysis. What is the recommendation? From this recommendation was agreed by 100%. Appears that single perioperative dose, single, of antibiotic compared to multiple doses does not increase the rate of subsequent infection. So there is no benefit to give multiple antibiotics, just 1 single, and this is agreed by 100% on ICM. And the last literature, 2019 in Philadelphia, by Parviz group, also they advised single dose of antibiotic. The last thing for our surgeon, good surgical craftsmanship will benefit from the prophylactic antibiotics. But a craftsman, bad craftsman, which not respect the tissue, cannot be replaced by antibiotics. To summarize up, first, antibiotics are suitable for perioperative prophylaxis. Antibiotic must be administered perioperatively 30 to 60 minutes. Drug concentration maintained until the wound is closed to last suture. Redosing is necessary according to pharmacokinetic in two cases if there is long surgery, more than 4 hours, or blood loss 1,500. Antibiotics are part of the prophylaxis, but not the tool for the prophylaxis from surgical site infection. This is class. Just always, I end my lecture by one of the cases. This man had total knee replacement, but fortunately, he was a 60-year-old man. Bilateral TKR before 2 years, right-sided knee pain, and night pain. We did all the inflammatory markers, ESR, CRP, and by aspiration, there is a germ. The germ means this is definitely a diagnosis of PJI according ICM definition of infection. So we did a mobile spacer, remove all the implant, irrigation, and wound cleaning, and applying mobile spacer for the knee and the poly, and applying the cement to the tibia. And this is the last revision for the patient. Next lecture for me to continue this series will be the most important. Always we searching about what is the biofilm. Is antibiotic affect the biofilm, the structure of the biofilm, and everything about this next lecture. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you.
So if there are any questions, please you can write it in the chat.
I'm ready to ask any questions. Yes, if there is any.
Thank you. Thank you so much, Dr. Mohammed Shihab. I'm Dr. Ahmed Latif. Thank you for this nice presentation. I just want to ask about the other modality of prevention of infection rather than antibiotic prophylaxis. A part of good preparation for the patient and good rubbing. Do you use locally in every case of total knee topical vancomycin?
You need local antibiotics, you mean, Dr. Ahmed Mo?
Yeah, local antibiotic, yeah, vancomycin.
In the wound? Mo?
Yeah.
That is a very important question. Actually, in ICM, this is high from many doctors, and this question is present. They recommendation was no. Local antibiotics has no effect on prevention of PJI. The preoperative, as you said, that dropping, last lecture, we talk in detail what we can do preoperatively. So regarding the dropping offsite and what type of the betadine or chlorhexidine with the iodine, it's proved that iodine with the bovine, with the alcohol is better than hexidine with alcohol. And I show the percentage of the infection where in this situation and this situation. But local antibiotics and those using with the calcium and phosphate, sometimes we apply it to the wound. There is no benefit, Dr. Ahmed. This is documented in ICM. And I can give you the question and the lectures which is achieved in this situation. So you can avoid it and you can apply it, but has no benefit.
Thank you,
so
sir.
you depend mainly upon the prevention of hematoma locally and good hemostasis with good irrigation rather than using topical antibiotic?
Yes, Dr. Ahmed, regarding the hematoma, we talk about that. Hematoma is nothing related with the infection directly, but hematoma sometimes will need blood transfusion. This blood transfusion will cause PJI. So you can avoid hematoma. We talk about what type of the anticoagulant to avoid it or continue. And better cauterization, of course. This is, I am sure that we are achieving that. But the problem with the hematoma, sometimes was huge, we're giving the blood, and this blood, one of the causing factor for PJI. Yes, I agree with you 100%.
Thank you so much, Dr. Ahmed. Thank you so much.
Not at all. Welcome, Dr. Ahmed.
Well, thank you. Well, we have another questions. From iPhone 6. Sir, I want to ask question from previous lecture. If a patient on antiplatelets, aspirin or clopidogrel, is it contraindicated to do surgery?
As we say, for the anticoagulant, it is for the aspirin or the like enoxaparin, it is better to stop it before the surgery about 12 or 24 hours. Even the Plavix. But to start after postoperatively, it need to check the PTT INR.
For sure.
For us, aspirin and potent anticoagulant is better to stop to avoid the bleeding during the surgery.
Yeah, of course. Another question. Thanks, sir, for this important talk. My question is the effect, Dr. Zaid Mahdi. My question is the effect of tourniquet on prophylactic antibiotic as drop. I think you mean, Dr. Zaid, if you do a preoperative antibiotic before or after the tourniquet application, is that your question? We want to clarify the question. So I have one important question is that before total knee replacement, we can get the antibiotic preoperatively. Oh, thank you, Dr. Zaid. Yes, he's meant to, sir, preoperatively antibiotic given before application of tourniquet if you are doing a total knee surgery.
For the antibiotic, as I told you, 30 minutes to 60 minutes for first generation cephalosporin or vancomycin before 2 hours. Mm-hmm. So when you're starting before half an hour or 1 hour, the patient is still in the ward. So not yes. reaching the surgery. And when you are reaching the surgery, during the process of the anesthesia, the patient having this antibiotics.
Enroll for the screening of patient.
Sorry, we didn't hear that question.
Let complete my answer.
Yeah. Thank you.
Okay.
Yes, please.
So then we can, when you are dropping that, we say slowly because the antibiotic must stay until last suture. When you tourniquet, there is still from the capillary coming blood. There is cutting the blood from the main artery, but from the capillaries, there's coming. So the antibiotics is coming to the area. Don't afraid, even if you want to use it or not use it, but to the last suture. This is the important.
Yeah, slowly. We have a note from Dr. Muhammad Al-Aidani from Al-Kindi Hospital. One of the most important things to decrease the risk of infection is tissue handling. Well, tissue handling is very, very important. Actually, we all agree that because tissue handling and aggressive, it may cause a dead space or may cause...
Any rule for screening patient before surgery? Thank you.
Dr. Assam, thank you very much.
دكتور راح اجاوب بس دكتور محمد.
Yes, please.
استاذ محمد. Yes, that's why I showed the last slide that if you are good craftsman يعني شغلك surgeon, you get benefit from the antibiotic prophylaxis.
Yeah.
And bad craftsman, no, will not get replaced by antibiotics. 100%, because the tissue restriction is very, very important to reduce PJI. Yes.
Yeah.
دكتور عصام الأخ دكتور yes دكتور عصام, I will talk last time about the prevention regarding the screening. I am talking for the prevention regarding the screening patient, especially for the nose, because most of them, 25% of the cases, the PGI is staph. And this 18 to 25%, this staph is present in the nose. So
Yes.
we say we can screen it, and if it is positive, we can apply either ointment or solution, ointment for 5 days and solution 1 hour before the surgery. Yes, screening very important, Ustad Assam.
Yes, sir. Thank you. And I think screening is very important and crucial to correct the patient's general condition, especially for the high-risk patients. There is another question from Dr. Imad Hassan. Welcome, Dr. Imad. Thank you for this informative lecture. The same measure, is it the same measure for diabetic patients, pre and post-operative?
دكتور استاذ عماد, هم ارجع اقول last احنا وضحنا for the diabetic patient the aim will be keep the السكر التراكمي يعني 7.5 to 8%. Before it, you can, if it is this level, you can do surgery. Above it, no. Correction, then reach corrected. Or it's 180 to 100. If it is above that, must correct it, then you are doing surgery. And fructose level, 293. This is parameter you can depend and to reduce the infection. So for me, it's, I always, I depend on 7.5, I only make surgery. Above it, no, please, go correct it and come through, because the risk of PGI in diabetic patient is high.
Yeah. Thank you, sir. Another question from Dr. Talib Hassan. Thank you very much, sir, for this talk. Do you think using tourniquet have any effect on joint infection in total knee replacement?
The tourniquet is a major issue. You know, it is causing ischemia for the surgical side. But the important is the time of the tourniquet. So if it is more than 2 hours, you must open it and re-tourniquet. And if you can open it without a tourniquet, because recurrent tourniquet will cause fusion. So the important, if you are working within 1 hour and 1.5, there is nothing, because you can keep everything is ischemic and do the surgery peacefully. The important thing, the timing of the surgery. Yes, if it's long period, yes, affecting PGI. And one of the causes, especially in diabetic patients.
Okay, thank you, sir. Another question from Dr. Ahmed Shujairi. Thank you, sir, for this wonderful lecture. I'm asking about the nasal swab. If it is positive, when we can repeat it, and is it a must to repeat before surgery?
Last lecture we say that it's 5 probe.
Yeah.
It's 5 probe taken from the nasal and applied to the agar for 5 days.
Yes.
So why you repeat it? If it is positive, because you apply to 5 drops to the agar, 5 agar. So if it is positive, you can apply your treatment perioperatively. And we say there is two type, ointment and solution. So you must treat it before the surgery, because about 25% is from the nose.
Okay, thank you. Dr. Muhammad Jassam, can the duration of surgery affect the infection rates? What is the ideal duration of surgery to say it's an ideal time?
Thank you very much, Dr. Muhammad. Actually, I search for this and I depend on ICM and another studies. Some of them says 100 minutes to redose. But ICM says it's 4 hours.
4 hours, yes.
4 hours after the surgery. That's why your antibiotic must be very slowly to the last suture that apply all the antibiotic to the surgical site.
And if every 120 minutes increase in the time, you can double the dose of a preoperative antibiotic. Is that correct, sir, according to the ICM?
Yes, because yes, that's why it's actually according to the weight, and there is equation. Yes, how much to give according to the weight.
Yeah,
yes,
of course.
You must keep in mind that body mass index, that if it's above 40, it is the triple the dose, original dose. And if it is between 30 and 40, it is the double the original dose.
Okay, another question from Dr. Anis. He didn't attend the past lecture, but he's asking about the general condition and serum albumin as a factor in infection rates.
Yes. Dr. Anis, last also on malnutrition point, we said the albumin, you must keep it above 3.5. Before 3.5, you must compensate for the albumin, because one of the risk factor for the PJI. So it's your standard 3.5. Keep it above 3.5 and above it. If it is below, you compensate before the surgery.
Well,
طبعا هاي النقاط اكثرها بالمحاضره الاولى، بس مع الاسف ما صارت كلها انذكرت يعني والهذه، بس معكم انا نعيدها او نذكر لكم النقاط من.
All right. Another question, two questions from Dr. Akram. He's thankful for the question, for the lecture. And question one: what is the effect of C-reactive protein titer on choosing the type of antibiotic type?
What titer?
C-reactive protein.
Dr. Sinam, he is talking about the diagnosis.
This
is it has nothing related to the this another search. If there is infection, and regarding synovial CRP, and we will talk about that in the definition of the infection, has 2 points. You know, if it is 6 and above, this is infection. 3 to 5 suspected. Below 3, it's not infected. How you collect this 6 point, we will talk exactly in diagnosis of the PJI. So for the synovial CRP, there is 2 points, but this is for diagnosis, nothing related to the prevention. Yes, and we will talk it later in detail.
And he is also asking about the alpha-deficient role in infection. Yes, it's also in the
diagnosis and has 3 points. Yeah. Now it has 3 points. Synovial, to use alpha-deficient, this is the new material. Yes. This is LigaSure for the Zimmer, but there's another company also using alpha-deficient.
Okay, another question is about the ideal pressure and time for tourniquet to reduce the infection, or what? I don't know. But he's asking about the ideal pressure and time of tourniquet in total knee replacement.
Ideal pressure for the lower limb 3.5. Yeah, 300.5. For the upper limb 200.5. But as the time is 2 hours, after 2 hours, you must open it, because there will be problems of the ischemia. And you apply it, if you apply it again, keep in your mouth, in knee surgeries, there will be recurrent fusion. So if you open it, please continue without
tourniquet.
Without tourniquet.
Especially if you have a tourniquet with leak, there may be a venous congestion. So open the tourniquet and do electrodiathermy, do a thorough hemostasis, and irrigate the wound. After that, you can continue the implant. Otherwise, as you say, doctor, there will be a risk of hematoma and infection risk. So I don't think there are more questions here. Thank you, sir, for this wonderful lecture. It was very nice, and we are waiting for the next webinar.
Thank you very much for my all colleagues And as I said, will be there is an implant. This will be distributed from the Ministry of Health and then from the new generation. So will be a lot of surgery. That's why I am concentrated in this subject to get all the ideas to prevent the infection. We are cooperate in that. And that's why I will give serious lectures. And if you apply 50%, that's good. For the bus, I'm concerned just one thing: antibiotic, single dose to the end of the suture. And this is my principle. And believe me, I have no infection for the last 2 years from this rule. And I appreciate all that to listening this 1 hour وتحملتوني. أنا ممنون منكم.
شكرا جزيلا. Thank you everyone. We will be meeting together in the next webinar. Thank you, Dr. Mahmood Shihab. We are very honored.
Thank you very much.